Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Well, what does a thoracic surgeon do?
You're the surgeon,
Yeah,
you tell me.
I'm going to tell you. They treat patients with diseases of the chest, and they treat primarily lung cancer, but that's not all. They also treat diseases of the chest wall and the esophagus.
That's the tube that goes from the mouth to the stomach.
Oh, Tracy, you know all the big words now.
I got it. Joining us by telephone from the Mayo Clinic in Arizona is thoracic surgeon Dr. John DeCuna. Welcome to the program.
Thanks. It's great to be here.
Hello, Arizona. Yeah, temperature nice down there, I'm sure.
It's beautiful. It's like 70 and sunny.
Oh, of course it is.
Always.
All right, so it's good to have you on the program. Let's start out with lung cancer, and I would assume that if you can cut it out, that's a good thing.
Absolutely. Lung cancer is a major killer of patients, and so whenever you can catch it early, taking it out to performing a surgical resection is the best chance for a cure.
And you have to be able to do that before the cancer has spread, right? If the cancer has already spread elsewhere, they wouldn't be a candidate to have the lung removed or the cancer removed from the lung?
Correct. Typically, if the cancer has left the chest and gone to the lymph nodes in the center of the chest or even beyond that, God forbid, surgery doesn't really do much to help with outcomes, and really chemotherapy and radiotherapy have more of a therapeutic role at that point.
That's what I was just going to ask. Do you start with surgery or do you start with chemotherapy?
Good question. It always depends. If it's early stage, that is stage 1 or stage 2, where the lymph nodes really are just locally involved, we start with surgery because that's the best outcome. And if the lymph nodes in the middle of the chest or beyond are involved, then we start with chemo and radiation. And sometimes patients can be a surgical candidate if they have a good response.
So what happens, tell our audience, if you remove part of the lung? Don't you end up with a hole there, and isn't it harder to breathe?
Another great question. We get this often in clinic. The lung, there's much like other organs such as the liver, you can remove a lobe of the lung safely in many patients, and their quality of life once they recover from surgery is not impacted. The body accommodates the remaining lobes shift to fill the space, and patients go on their usual daily life. The challenge is in patients with lung disease, which is sometimes why they come to us with a cancer. Sometimes they're not always a candidate for surgery because we can't take out, for example, a full lobe and leave them oxygen dependent. That just doesn't do them any good. So there are some more advanced techniques, like just taking a portion of the segment of the lung and things like that we often employ for those patients.
And how many lobes do we have?
We have 3 lobes on the right and 2 on the left.
And you can take one pretty much with impunity?
In an appropriate patient.
Yeah.
So, yeah.
Okay. And then the space is just filled up by the rest of the lung expands to fill the space.
Correct. And you might say, well, how can you not have breathing problems? Well, what I always tell patients, if you're a professional athlete, you're going to notice a difference, but the lung has a tremendous ability to accommodate, and the blood flow gets redistributed to the remaining lobes, and patients really with physical therapy and recovery do quite well.
That's what I was going to ask. It must make it hard to breathe, but I guess it doesn't. So I just need to go back. The lung is not like a balloon. There's like you said, when there's a lobe, that's like 3 balloons or 2 balloons. Is that how I can think of it?
Correct. Yeah, and it's divided into parts like that. So it's not just one big balloon on each side.
All right, we know that the esophagus is inside the chest, the tube that connects the mouth to the stomach. And some people, unfortunately, it's relatively rare, I think maybe only 20,000 cases a year in the United States, but cancer of the esophagus, you treat that also?
Correct. Yes, we take that out too.
What about the usual symptoms?
So what's interesting about esophageal cancer is it's actually what I would characterize an epidemic. It's on the rise quite substantially, and a part of it is related to our diets and reflux disease. So reflux disease is a predisposition for esophageal cancer. So what symptoms develop is a typical patient has reflux for many, many years, and then they come in with difficulty swallowing, and that's when they get an endoscopy to oftentimes what's diagnosed with an esophageal cancer, unfortunately.
So reflux, meaning that the acid from the stomach regurgitates back up into the lower end of the esophagus, and that irritation ultimately causes cancer.
Correct.
All right, and you said you could take it out? You can take it out?
Yeah, you can take out the esophagus, and that's what we prefer to do, much like lung cancer for esophageal cancer. We like to operate on early-stage patients, catching things early before the cancer has had a chance to spread, and we actually resect the esophagus and bring the stomach up high into the chest to form a hookup, and really what you're doing is replacing the esophagus and using the stomach as a conduit.
But again, the candidates would be people whose disease had not already spread elsewhere, correct?
Correct.
And what's the overall survival rate for patients with esophageal cancer? It's not so great, is it?
It's not so great, but your best chance is with surgery when we can get at it. And, the survival rates are improving. Again, it's different depending on your stage of disease that you present, but we have had, in the 20% 5-year survival is not uncommon. And that doesn't sound that great, but the other option is aren't that great either. And so there's a lot of work being done on newer therapies, minimally invasive approaches like we employ to try to optimize patients' outcomes.
Are you saying that most esophageal cancers are at the bottom part of the esophagus?
In the U.S., they are. They're mostly where the esophagus meets the stomach.
So how do you fix
because of that reflux?
How do you fix those cancers then that are higher up in the esophagus?
Early stage cancers that are higher up in the esophagus also get surgery. If they're really high in the esophagus, up in the neck, they oftentimes just best respond to chemotherapy and radiation therapy.
Difficult to operate on them way up there.
Correct.
All right, let's talk about operations for lung failure, and I'm thinking about people with emphysema. You have an operation for those patients?
We do, and those are patients who really go through a multidisciplinary evaluation that includes pulmonary medicine, surgery, and others. And when a patient comes in with emphysema, they may be a candidate for different interventions. Sometimes our pulmonary colleagues will put in bronchial valves to try to basically take that area in the upper lung and not have it ventilate, not have a wasted breath go to it, since the blood flow is preferential to the lower lungs.
So they plug the airway, the small airway that goes to the part of the lung that isn't working.
Correct. And sometimes patients are surgical candidates for that, where we go in and we resect that area of the lung in the upper lung fields and kind of fool the body into basically removing that lung that's not being used, and then the blood flow goes to the good lung. When that doesn't work, the final common pathway is often consideration for a lung transplantation.
All right, one other topic, lung infections. Do you ever become involved?
Absolutely. That's a major component to our practices also, when we're either having infections from pneumonia, which has gone bad, or other infections, and we see this a lot in different patients, especially down here in Arizona. There's a valley fever often involves the lung.
Now, oftentimes you're able to do these surgical procedures with minimally invasive techniques, right? And tell us how you do that.
Correct. We've used advanced techniques through small incisions and scopes and specialized instrumentation to perform the operations minimally invasive. And nowadays we're also employing robotic techniques in selected cases to perform the operations. And what that leads to is basically an enhanced post-operative recovery and a quicker return to daily work and daily function. And I also think it has less of a pronounced effect on the body and the immune system that allows patients to recover quicker and get on to the next treatment that's required for many conditions.
Incredible advances. Well, we know that thoracic surgeons treat diseases of the chest and the esophagus, and now they're able to do at least most procedures through minimally invasive techniques rather than having to spread the ribs to get in and do their work. Our thanks to thoracic surgeon Dr. John DeCuna from the Mayo Clinic in Arizona. Thanks, Dr. DeCuna.
Thanks for having me. Appreciate it.